It's a great question. I think we struggle with this a lot clinically because, unfortunately, our ability to predict who's going to have a complication from aspirin or other antiplatelet agents is very imperfect. At this point, we know there's certain clinical factors that might predict whether someone will have a complication. We know individuals who've had a prior history of bleeding or a prior history of an ulcer have a higher risk. People who've been infected with certain bacteria like Helicobacter pylori are at higher risk of ulcers. In addition, people who are older and have other comorbid diseases, other health problems, tend to have a higher likelihood of risks from aspirin therapy. That being said, though, there's still quite a lot of variation in an individual's risk of bleeding from aspirin. So I think a lot of work has to be done in trying to better understand what risk factors could be used to really help characterize better who's at risk. So there's a lot of research right now into developing risk scores to identify individuals at particularly high risk of gastrointestinal bleeding. Most of these risk scores have really relied on clinical factors, like I mentioned, such as age, history of prior ulcer, et cetera. So in general, those risk scores are things that are pretty easily adapted in the clinic and could be used pretty easily. But their ability to really define a high-risk population is still quite limited. So I think we still have to work to develop novel risk scores to really be able to better identify more specifically who's at risk. There are many individuals and investigators who have been working on this problem for a long time. And I think some of the more promising areas of research include using genetic factors to understand are there genetic factors that could be used to really identify a high-risk population. I think there's also people who are interested in combining genetics with some of these risk scores, and can you use clinical factors plus genetics to help define an at-risk population. So I think taken together, I think there is a hope for the future in really trying to use a more precise approach at how we sort of dictate and manage our patients with respect to providing aspirin for them. Yeah, it's a very good question. I think even as clinicians and physicians, I think we struggle with really balancing the risks and benefits for an individual patient. So it's an even greater challenge, I think, to be able to present those risks and benefits in a way that's easy for a patient to comprehend that may not have a lot of medical background. I think it's important for us to both convey the benefits in terms of the practical benefits and sort of what type of diseases aspirin could help prevent versus being very specific about the kinds of side effects. But even beyond that, I think it's important for us to be able to provide our patients some ability to weigh those different factors, because not all patients are completely familiar with, for example, what it means to have a gastrointestinal bleed, or what it means to have a specific complication, and how that should be weighed against something that they may have a little more understanding of, like what it means to have a heart attack or what it means to have cancer. So I think being able to provide patients a better understanding of the consequences to them with respect to quality of life and other factors, I think will be very important going forward. Yes, I think there is very good evidence to suggest that we can do more to prevent bleeding in particularly high-risk patients. There are certain medications that could be used in addition to aspirin to help reduce quite substantially the risk of bleeding. In particular, there's a class of medications which block stomach acid, and these agents have been shown to reduce the risk of complications from bleeding in people who are prescribed aspirin antiplatelet agents. We also, I think, are quite early, but I think quite hopeful in the future there might be an opportunity to reduce the risk of bleeding in other parts of the gastrointestinal tract. So we know that aspirin can cause bleeding, for example, in the small intestine and the colon. And our current approach to those don't necessarily support the use of these acid-blocking medicines, but they do support the idea that other types of agents could be used to help protect the lining of the small intestine or the colon to prevent those areas from bleeding. So I think there is the possibility that not only can we better identify who could bleed, but among those people that are particularly high risk, offer them something in addition to aspirin to help mitigate some of that risk.